Good morning, everyone. And today in diagnostics, we are going to talk about toxicology. So, toxicology, as if you have done forensic medicine, you are going like, I think you must be familiar with what is toxicology. Or if you will be doing forensic, basically, toxicology is covered in forensic in detail. And not from diagnostic point of view, but from medical point of view, we must know the important antidotes for the most common poisonings. So, of course, like this lecture is from diagnostic point of view, so I'm not going to talk about the antidotes because that is in the treatment. And um, in forensic, when you will study different type of poisonings in detail, so you will be covering that as well. So now, why toxicology is important? Like you can say, diagnostic toxicology. Uh, Simply, poisoning is a very important and you can say most common causes of hospital admission. So many people, when they get have poisoning, they are admitted to the hospitals. Sometimes the poisons are known and sometimes the poisons are unknown. So you can say like sometimes the cause or the poison is known and sometimes it's unknown. So basically what we do like in the hospitals, if the poison is known and there is a specific antidote available for that poison, so of course that antidote is given to the patients. But for example, when the poisons are not known, then there are many ways to control the poisoning. Like if the poison ingestion is not so, you can say, not too much time is passed, so the things are done to stop the absorption of that. And if like the intake of poison happened and there is like much of the time is already gone, so of course we do uh, treat the signs and symptoms and decrease the, you can say, the poisonous effect on the body. um, so most of the time, by the way, like poisoning could be accidental in reality, or it could like, or it could be, you can say, uh, by the prescribed drugs. Okay, and sometimes it could be due to drugs of abuse. So for example, I will tell you about accidental poisoning. Like you know, most of the medications which are available in home, uh, like paracetamol, like aspirin, like NSAIDs, things like this. So some of the medications, they are present in home, and for example, there are elder people who live in the same home, so they can be on any medications. Like it could be iron tablets, it could be uh, beta blockers, it could be antihypertensive medications, and XYZ. Any kind of medication can be there. And accidental poisoning can be due to ingestion of something which you don't know. For example, uh, many people, they put acids or things like this in normal bottles of cola and something like this. So accidentally someone can pick it up and can take one sip or something like this. So, or by the prescribed drugs, for example, someone who is prescribed on some drug and he have taken the dosage in a larger quantity. Now there could be many reasons for that. For example, for suicide purposes, or for example, again that could be accidental, or again that like that the babies can take, like that will come of course in accidental one. And the third, like, and one of the thing is like the drugs of abuse, like when of course like someone is abusing some drug and now they have taken too much of that, so that can cause. So the management of poisoning basically depends on many factors. Of course, like we are not discussing right now the management, but we are discussing the diagnostics. But just to tell you some preface or the background of the condition makes some sense, right? So um, the management of the patient is mostly supportive, and it is mostly done on the basis of increasing the excretion or increasing the metabolism of that medication in the body. And as I told you, if we know the antidote, we can give that antidote. But if we don't know the antidote, if we don't know the poisoning, or if the antidote is not available, then of course will go symptomatic. We will go on supportive measures. So now the important thing over here, because we are studying the diagnostics, right? I can give you the example of paracetamol poisoning. Paracetamol. So now paracetamol poisoning is one of the most common poisoning, guys, because this medication is present almost in every home. Okay, so you can say now paracetamol. If many people don't understand what is this, so it is basically acetaminophen. Okay, basically it is like called acetaminophen in USA, and in Britishers they call it as paracetamol. So paracetamol is one of the very common medication which can be taken in overdosages. Okay, so you can rather say the most common drug taken in overdose. Okay, like this one. So of course, like because this one is present in every home, this one is readily available. Many people they have access to this thing, so that's why. So whenever like paracetamol is taken in higher dose, so what happened? Like what these drugs do, like this one basically depletes the antioxidant stores in hepatocytes. So when this thing occurs, so what will happen? Like liver damage will occur. Okay, liver damage will occur. Now, the important point over here is simply uh, depending on like how much dose is taken, of course, right? So like based on, because you can say there is what you can say dangerous dose of paracetamol, which if is taken to in that much limit, of course, like it will give the sign and symptoms of the patient, right? So simply, uh, what happens is, if you know, paracetamols, like I'm not talking about China. China have like different type of dosage, which I don't know like what's the reason behind them, but like in most of the world, paracetamol comes in tablet form and syrup forms and suppository forms and injection form as well. But like if I will talk about the tablets, it comes mostly in 500 milligram tablet. And most of the time, when someone needs paracetamol, they can take 2 tablets. That means 1 gram. Okay, so they take 1 gram each time. And that's why, like they say that no one, so like you will be taking 2 tablets every 6 hourly, for example. So that will make 4 times in a day. So you can say you will be taking 4 grams in 24 hours. Okay, usually is the recommended daily dose. Okay, so what happens? A very easy way to remember this one is um, anyone who have taken, you can say, uh, 200 milligram per kilogram. Okay, so 200 milligram per kilogram, which means what? Basically, 1 gram for 5 kilograms. Okay, so like 200 multiplied by 5 will be equal to 1 gram. So 5 kgs can take 1 gram, and again, which means a 10 kg guy can take 2 grams, and a 60 kg guy can take 12 grams. Okay, so this dose is surely lethal dose. One easy way to remember, guys, anyone who takes 12 grams in 24 hours, okay, that is surely a lethal dose, a dangerous dose. Some of the books mention 10 grams as well. Okay, so what happens? We consider like the patient have, okay, now one of the leaf of paracetamol usually have 10 tablets, so which means like it have 10 grams of paracetamol. So if someone is consuming one whole leaflet in one go, he have already taken 10 grams. That is again too much. Okay, so that's how this thing occurs. And as I told you that it depletes the antioxidant stores in the hepatocytes. Guys, basically when you will study this thing in detail, I don't know, in forensic or whatever, in internal medicine, you would know, basically we need glutathione or glucouronic acid in the liver. Okay, so what happened that whenever like these antioxidants are uh, what you can say are gone or depleted by paracetamol, of course, like there will be uh, stress to the liver, which will, like, it is going to damage the hepatocytes. And if you remember, like there is a system called a cytochrome P450 system, or cytochrome P450 enzyme system, that is going to basically shut down, and that's the reason the liver will be damaged or will start getting damaged, right? So I think like that is like too much explanation. Like we are not talking until now to our main topic, and until now, like we haven't have gone to that. So what happens, by the way, um, like anyone who presenting with um, or you can say, okay, I will go on the lab features directly, right? I will not talk about the clinical features, because okay, clinical features, I think it will be better for you to understand like this way. It is going to damage the hepatocytes, right? So whenever it is going to damage the hepatocytes, guys, we go for LFTs. Why? Because the liver is damaged, right? So what we check the liver enzymes, and we had done this liver enzymes things, right? So I think like it will be easy for you to understand what are the liver enzymes. If you remember, like they are simply um, aspartate transaminase and alanine transaminase, okay, which are also called as SGOT or SGPT. So simply their level is going to be raised, okay, whenever there is any liver damage, and bilirubin will be raised as well. Okay, these are basically tests of the acute damage to the liver, because suddenly when the hepatocytes will start getting damaged, what will happen? AST and ALT are going to raise, bilirubin are going to raise as well. Okay, now Basically, like what we do is we divide the liver function test into two main categories. One, we call it as the test of acute damage, and some are the what you can say the tests of for the chronic damage or the chronic failure, liver failure. For example, when someone liver is not working, they cannot produce proteins, and when they cannot produce proteins, what will happen? Like clotting factors are protein as well, so their clotting things go wrong. So simply they will present with elevated uh, prothrombin time. Now again, see, actually when you are teaching online, so you are not sure like how many of you are understanding, because now I don't know like how much you have the concept of coagulation and what is prothrombin time. So basically prothrombin time, which is basically the extrinsic pathway, and what happens, like we use warfarin, which is an anticoagulant, and like it increases this time. And most of the labs nowadays, they basically give you test as international normalized ratio rather than PT. So basically INR, or international normalized ratio, is calculated from PT, which is prothrombin time, and it can get impaired when the liver cannot produce the clotting factors. Okay, so this is like the thing which is going to occur. Now what happens. There is something called as hepatorenal syndrome now. When you are going to study cirrhosis, especially, you would understand one thing, that whenever the liver get damaged, or whenever there is liver failure, what happens is the kidneys will also shut down, or there will be malfunctioning in the kidneys. We call it as hepatorenal syndrome. Hepatorenal syndrome, like the renal problem, is basically due to the liver. If we are going to fix the liver problem, the kidneys will start working fine. There is basically no pathology in the kidneys. We call it as hepatorenal syndrome, or you can say, in your words or easy words, you can say it is simply renal damage secondary to liver impairment. Okay, so this thing. So simply, whenever someone have paracetamol poisoning, what happens is, guys, they have abnormal renal function test, which is increased um, urea and creatinine. Okay, so this thing is going to occur in these patients, and the liver failure in this case is also going to cause metabolic acidosis. Okay, so one of the abnormality will be metabolic acidosis. So this one are due to liver damage, this one due to hepatorenal syndrome, and this one is due to metabolic acidosis. And metabolic acidosis, what kind of test we do, you will completely understand when we are going to discuss the atrial, arterial, blood gases. And what happens in these patients is basically they have um, high anion gap metabolic acidosis. Okay, so yeah, like right now you won't understand, but then when we will talk about arterial blood gases in the coming lectures, you will understand what's going on. So like these are the lab findings, I'm talking about in paracetamol poisoning. So what we do basically, we what whenever like someone have liver damage, we administer them with antidote. And what kind of antidote we give them in paracetamol poisoning? We give them, the antidote is um, again, this is, I'm going away from the topic, and acetyl cysteine. Okay, so basically we give them this an acetyl cysteine, which is the antidote for paracetamol poisoning. So what this antidote do it basically um, try, like it basically go and it replenish, or you can say remake the uh, deficient antioxidants, like the antioxidants which are depleted, so it is going to reinstate them, you can say. So this thing is given. Okay. So by the way, what happened in the hospitals is, uh, like in clinical practice, what I mean to say in hospital is like clinical practice. Um, we don't measure the level of the drug in the blood as soon as after someone have ingested the drug. Uh, Basically, we rely on the levels of paracetamol in the blood uh, almost around 4 hours after ingestion. Okay, and by the way, it's a reality. Like no one can reach the hospital without like by taking the drug right away. Rather, it takes like at least half an hour or 1 hour to reach the hospitals. So N-acetylcysteine is quite safe and effective drug. Just few of the side effects are reported, but uh, in the routine practice, this drug is not given to the patients. But what we do in the labs is we measure the blood paracetamol levels. So of course, like this is the new thing, right? So all of our lecture is about this thing. So we measure the level of paracetamol in the blood. Okay. So now what they use something called as normogram. This is called as normogram. Okay. This is called as normogram. Now you can see over here, this is the blood paracetamol levels. This is the time since ingestion, and this is also the blood paracetamol level, but in different. This is milligram per liter. This is micromole per liter, right? So what they do, and see, for the first 4 hours we don't rely on this normogram, but what happens after 4 hours we check the blood paracetamol levels. For example, we will measure at 6 hours. At 6 hours, if someone have this much level, no need to do anything. Okay. If someone have after 12 hours this much, again no need to do anything. But if someone have this much levels after 20 hours, treat. So this orange is the treatment zone. So at 6 hours, if someone have this much levels, 140 milligram per liter, of course treatment is required. Or if, for example, at 12 hours someone is over here, or after 20 hours someone is over here, they need treatment. So you can say the timing of the overdose is very critical to know, because this blood levels, we interpret this normogram on which we can trust, or on which we decide that the patient needs any treatment or not, is basically when we know the time of ingestion, and we can calculate 4 hours after that. Okay. And see this normogram lines, if you will notice, it is starting after 4 hours. So the blood levels are taken 4 hours post ingestion, because before this time the absorption is not complete. Okay. So once we will establish the timing, so we will keep on taking we will check the 4 hour blood sample, and then we will keep on taking samples every 2 hours, and we keep on plotting it on this normogram, and we will decide either like these values lie in the yellow zone or in the orange zone. Okay. So if the patient levels are above this line, okay, at any time, of course, so they are the one which we think like, or which we take at like they are at risk of getting liver damage. So then we administer antidote. Okay. But if their levels are below the treatment line, so the risk of their liver getting damaged are very, very, very small, and the treatment is generally not required for these patients. Okay. So one thing you can say to administer this thing, what is important? Timing of ingestion is critical to know. Okay, and sometimes it is difficult to know about this thing because the patients maybe the patient who have taken the drug maybe cannot speak, maybe drowsy or maybe uncooperative. But like of course in clinical practice we uh, try to gather information from all the sources which we can. Okay, uh, like just to establish the right time um, of taking the drug. Okay, uh, so this thing. So for example, if the details are sketchy means like you're not sure either the details are normal or not. Okay, so uh, you can say uh, if you will see over here, the chart is very steep over here, but it is flattening over here, right? So what happens? Uh, that the difference in the blood levels between someone to treat or someone not to treat when the presentation is delayed is very small. See, if we know the timing and we know that the person is presented with, and we know like there's 4 hours has passed after ingestion. So see, a high level of area we can play. So if the patient have a very high level of paracetamol, that's fine. Or for example, if the patient is presenting with 8 hours, see, we will not treat even the drug levels are very high. But see, here it is flattening. So at 20 hours, see, even if the level is, you can say 17, look, you have to treat. At 18 hours, even if the levels are 18, you have to treat. At 16 hours, even if the level of 20, you have to treat. Or at 22 hours, even the level of, you can say, 8 or 9, you have to treat. Understand? So see, this is the significance of this thing. So you can say like when the presentation is delayed, the demarcation who to treat and who do not to treat is very, very, very small. And in this case, of course, we can give an acetylcysteine to every patient. Okay, so easy concept, not so hard. So remember the lethal dose if anyone have taken more than 12 grams. Okay, and the patient is presenting within 4 hours, and the patient is cooperative, and he told like he have ingested. So of course, like this normogram is very, very, very helpful. So uh, this is the most important point you have to remember in this one. So okay, by the way, this normogram is not so simple because or you can say I am putting the most simple normogram over here, but there are like the normogram is a little complex because there is a small line here also. If some patient have any comorbidity, if a patient already is a patient of liver damage, then the treatment threshold come lower. So simply what it means, we started treating them even at lower dosages of the drug. Okay, so why? Because if someone have liver damage already done or already going on, for example, if the patient is a patient of chronic liver disease, okay, uh, due to any reasons, due to alcohol, due to autoimmune hepatitis, due to viral hepatitis, so in those the threshold of the treatment is quite lower than how we treat the normal people. Okay, or you can say the people who are at high risk, patients at high risk in paracetamol poisoning. So uh, alcoholics, I messed up the spelling of alcoholics, malnutrition, AIDS, of course, The patients on drugs or the enzyme inducing drugs. So, for example, if the patient is taking rifampicin, carbamazepine, or phenytoin, so uh, these are the enzyme inducing drugs. So, of course, like they are at increased risk, and of course, like chronic liver or chronic hepatitis, simply that will cover almost everything. So, these are the causes, in which like um we take this line, the lower one. Okay, of course, like this one is the most simplest one I'm putting. They have like one more line over here, right? For those who are at high risk and like their treatment threshold is not like normal people, rather we treat them even when the levels of the um paracetamol are even lesser, okay, in the blood. So that's all, guys, for about paracetamol poisoning. And I think like I will discuss like in the next lecture about 2 3 more poisonings, but not this much in detail, but rather I will pass them on, okay, and then we'll talk about some other topics. Thank you so much for listening.